All right, so let's talk a little bit about antimicrobial treatment here, chapter 10 in your textbook. So, the introduction of modern drugs to control infection was a medical revolution. Began in the early 1940s. Uh, Penicillin was the first antimicrobial drug that showed a good promise. These drugs have reduced the incidence of some infections, but they have not eradicated infectious diseases, and they probably never will. Today, the main concern of doctors and the medical establishment is we are dangerously close to what is being referred to as the post-antibiotic era, where the drugs we have are no longer going to be effective. And we will talk a little bit about in this chapter about why that is. Main issue is overprescribing on the part of physicians and failure to properly take the medication by patients. The goal of antimicrobial chemotherapy, and chemotherapy is a word that we're going to define as using chemicals to treat a disease. Most of us, when we think about chemotherapy, we think about cancer treatments. But the definition of chemotherapy is the use of chemicals in a therapeutic way, trying to get rid of a disease, cure a disease, control a disease using chemicals. Administering a drug to an infected person that destroys the infectious agent without harming the host cells is the goal of antimicrobial chemotherapy. To do that, there are several things the drug must be able to accomplish. It must be easy to administer and able to reach the infectious agent anywhere in the body. So again, not something that necessarily you have to be hospitalized, for instance, to administer. So easy to administer. It should be absolutely toxic to the infectious agent and absolutely non-toxic to the host. Now, again, this idea, these concepts are ideal situations. We all know that sometimes that antibiotics and chemotherapeutic agents do cause harm to the host, but we want to be as toxic to the infectious agent as we can be, while at the same time being as non-toxic to the host as we can be. And it needs to be active in the body as long as needed and to be safely and easily broken down and excreted. This is one of the problems with patients taking their medications correctly. It doesn't remain in the body. The body breaks it down and excretes it because they're not taking it in the proper way. The characteristics of an ideal antimicrobial drug: it should be toxic to the microbe, but non-toxic to host cells. It should be microbicidal instead of microbistatic. And again, the ideal antimicrobial drug. It should be soluble, and it should function even when highly diluted in body fluids. It should remain potent for long enough to act. It is not broken down or excreted prematurely. It should not lead to the development of antimicrobial resistance. This is a causative problem, and again, leads back to the way they are prescribed and the way they are taken. Complements or assists the activities of the host defenses. In other words, it should not work antagonistically to the immune system of the body. It should work synergistically with that, but with the body's immune system. It should remain active, whether it's in tissues or body fluids. It should be readily and easily delivered to the site of the infection. Again, one of the things we have in the early days, folks would have an infection in their toe, and they were saying, well, why am I swallowing a pill? Why am I not smearing something on my toe? So it has to be able to get it to the site of the infection. And it should not disrupt the host health by causing allergies or predisposing the host to other infections. And again, this one down here is an issue with both men and women, but especially with women. When women take large courses of antibiotics, oftentimes they will develop a yeast infection because the drug has actually opened the body up to those other infections. But again, these are the characteristics of an ideal antimicrobial drug. Some terminology for antimicrobials: prophylaxis, which means using a drug to prevent infection of a person at risk. Maybe you're fixing to go on a canoeing trip down the Amazon, and you will take a huge course of antibiotics leading up to that as a prophylaxis. Antimicrobial chemotherapy, the use of drugs to control infections. Antimicrobials is an all-inclusive term for any antimicrobial drug. An antibiotic, the important thing here is these are natural metabolites produced by some microbes that destroy other microbes or inhibit their growth patterns. A general term, these are used for targeting bacteria. A semi-synthetic drug are chemically modified in the laboratory after being isolated from natural sources. So we take an antibiotic, a naturally occurring metabolite, and then modify it in some way. That would be a semi-synthetic drug. Penicillin is an antibiotic. Amoxicillin and some of those other cillins are semi-synthetic drugs. A synthetic drug is one that is produced entirely by chemical reactions in the lab. A narrow spectrum drug is one that is effective against a very few bacteria or microbes. It has a very limited spectrum of activity, so we call those narrow spectrums. A broad spectrum is going to be effective against a large number of different microbes, and we sometimes say that has an extended spectrum. Antibiotics are originally metabolite process or products of bacteria and fungus organisms. They are produced to inhibit the growth of competing microbes in their habitat. So again, the antibiotic was not made by the bacteria or the fungus for us. It was actually made to benefit the fungus or the bacteria. We have just sort of co-opted that and used it for our own purposes. The greatest number of antibiotics are produced by two genera of bacteria and two genera of molds, the Streptomyces organisms and the Bacillus organisms in the bacteria, and the Penicillium and the Cephalosporums. I hope everybody can guess where the antibiotic cephalosporin comes from. We all know where penicillin comes from. Where do you think streptomycin comes from? There you go. Before actual antimicrobial therapy can begin, we must consider three things. Number one, what is the identity of the microorganism causing the infection? My wife worked in Children's Hospital for 20-odd years in one of the general pediatric clinics, and their biggest issue was parents who would come in with a child who clearly had an upper respiratory infection that, based on the color of what they were coughing up and some other issues, it was clearly a viral infection, yet the parents still wanted an antibiotic. Well, antibiotics don't work against viruses. So the identity of the microorganism is very important. The degree of the microorganism's susceptibility, also called its sensitivity to various drugs. All right, we've identified the organism, and then we have to determine, can we give a small dose of antibiotic A or a large dose of antibiotic B? Which one is the best option for us? And we have to look at the overall medical condition of the patient. Is the patient severely immunocompromised? Is the patient already in the hospital recovering from some condition? We have to understand that the drugs we give can affect the overall condition and health of the patient. Identifying the agent. In the old days, we used to do this in the microbiology lab. We would take an unknown organism, we would give it to students and let them identify it. The problem with that is it takes an awful lot of material and several weeks to do it the old-fashioned way. And when you start having multiple labs, then it becomes an issue with space and size, so we simply don't do this anymore. But the way you do it is you do a series of tests. You should identify the infectious agent before antimicrobial drugs are given, before their numbers are reduced. You can do this by looking at direct examination of body fluids, looking at their sputum. You can look at stool samples in a rapid method for detection. Again, if you are a parent and you've ever taken your child to the clinic with a sore throat, they would have probably performed what is called a rapid strep. They would take a swab, stick it in the back of the child's throat, run that out on a slide, and very quickly they could identify whether or not that was a staph organism or strep organism or whatever. And if it's a positive rapid strep, then they start the child immediately on a course of antibiotics for streptococcal organisms. Doctors often begin therapy on the basis of immediate findings and informed guesses. If you are a doctor and you're running a clinic and you have several hundred patients, or maybe even as the case was at Children's Hospital, there were several thousand patients that were patients in the clinic where my wife worked. And if the doctor has seen 25 cases this week of a particular type of upper respiratory infection, and another child shows up with an upper respiratory infection, he's going to assume, or he's going to use the term this textbook author uses, guess, that that student probably has the same thing. Everybody in a class suddenly breaks out with little sores all over their body and running a low-grade fever and just feeling itchy and miserable. Chances are they've all probably got chickenpox, which is a virus, but again, that diagnosis was based on a guess. Epidemiological test, excuse me for that, I'm sorry, I thought I had turned that off. I'm still trying to turn it off. There, finally, sorry about that. But we may use statistics. Again, this is where the doctor contacts his fellow clinicians around town, and lots of people are coming in with the same type of gastrointestinal upset, so he bases his diagnosis on that. You then test for drug susceptibility. You can test for the following organisms: Staphylococcus species, Neisseria gonorrhoeae, the causative agent of gonorrhea, Enterococcus facialis, and you need to test for aerobic gram-negative intestinal bacteria or bacilli organisms. If treatment is ineffective for fungal and protozoan infections immediately, drug testing is very essential. In general, these tests involve exposing a pure culture of the microbe to several different drugs and observing the effects of the drugs on growth. Here in a minute, we will talk about a way that is done using tubes and little paper discs, plates and little paper discs. And this is an experiment that we actually do perform on this campus in our lab. It is called the Kirby-Bauer technique. The surface of an agar plate is spread with your test bacteria or your unknown organism that you have taken from a patient. Small paper discs that have been soaked in a prepared solution of antibiotics at a particular strength is placed on that disc. As the bacteria grow, if those bacteria are susceptible to that particular antibiotic, no growth will occur around that disc as the antimicrobial diffuses out into the medium. Uh, the bacteria will not be able to grow. Those zones or those areas where no growth is occurring around the disc is referred to as a zone of inhibition. That zone of inhibition will be measured and compared with a standard for each drug. The standard will say if the zone is bigger than this against a particular uh, uh, infectious agent, then it is considered to be an effective drug. And here is a chart. Again, I will not ask you to memorize this chart. Those of you who are in lab with me, we will actually be doing a test similar to this. Those of you who are taking my online lab, you will be presented with data saying that you put a bacteria, you put E. coli onto a plate, and it made a zone this big. Is it susceptible or resistant? Then yes, S stands for sensitive or susceptible. R is for resistant, and I is for intermediate. You would probably want to use the drugs against particular bacteria using the ones that are the S's. For instance, if you have, excuse me, if you have your bacteria and you try neomycin and you get the zone required for resistance, you have to get here. So you wouldn't want to use that drug against that particular agent. Here is an example of a Kirby-Bauer test. We swab, you can see the lines here. That's where they swab the entire surface of the bacteria. And usually when I tell my students in lab to do is to swab it this way. And you can kind of see that this student has done this. You swab it this way, and then you turn the plate 90 degrees, and then you swab it ultimately this way. And you can look right in here, and you can see where the lines are going this way and this way. You can see whatever antibiotic this is completely ineffective against whatever bacteria this happens to be. But this one and this one seem to be very good. This one's okay. This one is good. This one works a little bit, but again, that looks like vancomycin and maybe erythromycin there. Whatever this bacteria is, these organisms are completely useless against it. And here is an artist's rendering showing you, these are what the paper discs look like. The letter represents the agent. The number represents the strength. You measure, again, you would measure that zone of inhibition from here to here. That says it looks like it's about 27, and it says, greater than 22 is good. So that's the way you do the Kirby-Bauer test. Now, there is another sensitivity test, which, as far as I know, this does not have a name, and you can't tell very well looking at this plate. But here is tetracycline, and you see a little bit of a zone here. And there's erythromycin 15, and you see a little bit of a zone here. This is another type of strip showing the way the bacteria are growing. And again, you can see a somewhat of a zone around here. And that's, again, I have never done this particular test, but it's just another sensitivity method telling you whether or not whatever this bacteria, whatever this antibiotic is it effective against this particular bacteria. Tube dilution tests are more sensitive and more quantitative. Remember, when we say quantitative, we're counting numbers here. These are more quantitative and more sensitive than Kirby-Bauer. The antimicrobial agent is diluted in a method called a serial dilution. And we'll have a picture here, and I'll show you what that is in a minute. Each tube is then inoculated with a small uniform sample of pure culture. It's incubated and then examined What we mean by a small uniform sample, it means we're putting the same amount of that pure culture into each one of these test tubes. You don't want to put, a milliliter in one tube and half a milliliter in the next one. You have to make sure the samples you are using are the same. This test will give you what is referred to as the minimum inhibitory concentration, or MIC. This is the smallest concentration of a drug that visibly inhibits growth. These are useful in determining the smallest effective dosage and providing an index against other microbials. So again, it could be that one drug using this test, the Kirby-Bauer method, this is Kirby-Bauer, may say to use this drug, but by doing this test, you can see that, let me back up the page again, while this looks like it would be the better drug, we might want to use this one because we'd have to take less of it over a shorter amount of time. We might have to take 15 units of this for 10 days, but we could take 30 units of this for 5 days. Make sense? All right, and here is a serial dilution test, the tube dilution. Here's my control. Here is a 2% solution of whatever the organism is. There's a 4.4%, 4.8. So basically what we did is we took a sample of this and put it into here. And then we took a milliliter of this and put it into here. Generally, these tubes will contain 9 milliliters of nutrient broth. Okay? You will take 1 milliliter of this, put it into here. You have 9 plus 1 is 10, right? You're then going to take 1 milliliter out of this and put it over here. And then 1 out of here and put it over here, etc., etc. And each time you are decreasing the concentration. And if you'll notice out here, there are still a few cells growing there. By the time you get to this one, this 6.4 dilution. So when you get to the 6.4 dilution, that would be the minimum inhibitory concentration. This is just a different way of doing things. This is called a 96 well plate. When we get toward the end of the semester and we do the simulated AIDS test, you will use one of these little 96 well plates. The red represents the bacteria is growing, and the X represents the concentration where it stopped growing. So for these organisms, these are my agents of control. Which one would be the best one to use based on this data? Well, this one would have the greatest inhibitory. This one would have the lowest inhibitory. Okay. In vitro, responding to treatment. In vitro activity of a drug is not always correlated with the in vivo effect. Failure of an antimicrobial treatment is usually due to, number one, the inability of the drug to diffuse into that part of the body, the brain, joints, skin. This can be included the possibility that the microbes are in a biofilm. Resistant drugs in the infection, or resistant microbes, excuse me, in the infection that did not make it into the sample collected for testing. An infection is caused by more than one pathogen, some of which are resistant to the drug. And in outpatient situations, you also may have to consider that the patient did not take the antimicrobials correctly. The ratio of the dose of the drug that is toxic to humans compared to its minimum effective or therapeutic dose is a calculation one can do. That's the therapeutic index. The smaller the ratio, the greater the potential for toxic reactions. If your therapeutic index is 1.1, that might not be a good choice. If therapeutic index is 10, that would be a safer choice. So again, back to those tests that you were doing. The one drug may have a bigger, make a larger zone of inhibition, but if it's got a 1.1 therapeutic index, you may not want to use it over a drug that had a slightly smaller zone of inhibition, but has a therapeutic index of, say, 15. The drug with the highest therapeutic index is going to have the widest margin for safety. It's least likely to cause an adverse reaction with your patient. Physicians, before prescribing any antibiotic, should carefully look at the history before prescribing that antibiotic. Number one, does the patient have a pre-existing condition that might influence the activity of the drug or the response to the patient? Certain drugs, for instance, certain antibiotics should not be given to diabetics. Diabetics have chronically slow diffusion rates. Their tissue perfusion is not as good as it should be. Therefore, you may need to keep that in mind. A patient has an allergy or a history of allergies to a certain class of drugs. If one is allergic to penicillin, probably shouldn't take amoxicillin or ampicillin either, just to be on the safe side. Does the patient have underlying liver or kidney disease? These are both diseases that can be adversely affected by antimicrobial treatments. Infants, the elderly, pregnant women. We have to take special precautions with infants and the elderly and pregnant women. Intake of other drugs can result in an increased toxicity or failure of one or more drugs. When you go to your doctor or go to a doctor and they want your medication list, they are not being nosy. They have to know what drugs you are taking, because certain drugs have what are called contraindications. Certain drugs react adversely with other drugs. So if you are taking a particular type of blood pressure medicine, for instance, we don't want to give you another medicine that's going to further lower your blood pressure. Some drug combinations have synergistic effects and may allow for reduced dosages. So sometimes the doctor will say, okay, you're already on this, then I can give you this, and it will be an even smaller dose because it's going to work synergistically with something you're already taking. Choosing an antimicrobial drug is an art, and it's a science. Even once all the information comes in, the final choice of a drug is not always easy or straightforward. You got two hypothetical cases here. An elderly alcoholic patient with pneumonia caused by Klebsiella and complicated by diminished liver and kidney function, requires parenteral drug administration and has a history of allergy to penicillins. The go-to for Klebsiella pneumonia is penicillin, but you don't want to give a patient who is allergic to penicillin. But if this patient had never told anybody that they were allergic to penicillin or that they had diminished liver and kidney function, we would have immediately prescribed penicillin and they would have had an allergic reaction. Another hypothetical case, a cancer patient who has severe systemic candida infection. Candida, this is a yeast infection. If you're, again, parents out there, if you've ever had thrush is caused by Candida albicans, which is, again, it's a very common fungal infection. So again, you've got a cancer patient this infection, you want to make certain whatever drug doesn't affect this, or excuse me, does affect this without disrupting their cancer treatments. All right. Going to call it a day for there. We will pick back up at a later time. Everyone have a great day. See you next time.